Hello, this is Dr. Joanne Manson, professor of medicine at Harvard Medical School and Brigham and Women's Hospital. I'd like to talk with you about some worrisome findings from the Virgo study, the variation in recovery, role of gender on outcomes of young AMI patients. This is a study recently published in the Journal of the ACC, or JACC, by investigators at Yale. I think the findings could be viewed as a call to action for more attention to address the needs of this high-risk patient population of young women with MI. We've known for a long time that younger women below age 55 who are hospitalized for MI tend to have higher in-hospital mortality rates than men with MI of similar ages. However, we haven't known the outcomes after discharge or had a good understanding of rates of readmission and outcomes after discharge. And this study in JACC looked at about 3,000 patients who had an MI, hospitalized for MI between the ages of 18 and 55 at 103 U.S. hospitals, looked at sex differences in rates of coronary and non-coronary hospitalizations and admissions over the subsequent year after discharge. And what they found was that women did have significantly higher rates of both coronary and non-cardiac hospitalizations over that next year, about 33% higher risk of cardiac hospitalizations and 51% higher rate of non-cardiac. And why would this be? Well, they looked at several possible explanations. One was looking at the risk factor status of the women when they were hospitalized for the index MI. And they found that women did tend to have a higher prevalence of comorbidities and risk factors, such as women were more likely to have hypertension, high BMI, COPD, prior history of stroke. They also found that women were more likely to have certain socioeconomic factors and social determinants of health associated with more adverse outcomes, including more likely to be low income, about twice as likely to self-identify as being non-Hispanic Black, and also a higher prior prevalence of depression or prior history of depression. During the hospitalization, at the end of the hospitalization time of discharge, they looked at the rate at which guideline-directed medical therapies were being prescribed. And they found that there were significant disparities, that women were significantly less likely to receive these guideline recommended therapies such as statins, aspirin, beta blockers, ACE inhibitors, or ARBs. So there were several possible explanations for these poor outcomes. It really suggests that this is a very complex issue. It needs to be addressed from a number of angles. One angle is primordial and primary prevention. Women really need to understand that they are at risk of heart disease, as are men. This is not just a men's disease. We need to do more to increase awareness of heart disease as a health threat among women, even among young women, and really try to manage risk factors well to prevent the MI. But also, it's just tremendously important that we eliminate these these disparities in terms of the recommending the guideline-directed care, such as statins and aspirin, that these rates no longer have differences between men and women. And so a lot can be done in that area. But also it suggests that more needs to be done in terms of addressing psychosocial issues and social determinants of health. Dr. Martha Gulati wrote an editorial on this paper and did highlight that attacking this problem, addressing this problem, will require attention to at least three areas: individual risk factors, healthcare policies, and healthcare system-related factors, as well as healthcare and public policy. And I think we really do need to pay more attention to these issues in order to make real progress in this area. Thank you so much for your attention. This is Joanne Manson.